morning, everybody. And that is a nice gathering, though it's a Sunday morning. I wish to thank Dr. Khanna for the opportunity to give this lecture. I wish to speak to you on PET-CT in prosthetic vascular graft infections. So as we all know, prosthetic vascular graft infections are not very common, they are infrequent, but it's a very serious complication of vascular surgery. The rate of vascular graft infections are not very high, but at certain aortic graft infections, it can even range up to 12%. And normally it's between 0.5 and 5%. Mortality rates are high in these patients once the graft gets infected. It can have very severe morbidity in terms of limb loss, etc. Obviously we select the best patients and we don't want infection, but unfortunately certain patients have risk factors. They may be on immunosuppressive therapy, diabetic mellitus, cancer, etc. can increase the risk of infection. And as we know, prognosis depends upon the site of graft and if whether the patient had infection prior to surgery. So the graft infections can be early or late. I'll not go into all these things which you know, and you diagnose infection by the local pain or ischemic pain, fever, pulsatile or purulent mass, overlying necrosis, and you can have leukocytosis, perigraft abscess, bacteremia, etc. And the late infections, you may have sinus formation, anastomotic aneurysms, recurrent cellulitis, etc. So what is the most important point when we are dealing with infection? One has to rule out the site of infection is very crucial. Whether is it arising from the graft or is it from the surrounding tissue. The infection is in the surrounding tissue next to the graft. This distinction is very, very important. So the management depends a lot upon the site of infection. So what are the different techniques that are available to us to diagnose and clarify the site and nature of the infective process? You have ultrasonography is useful to ascertain the graft patency and surrounding pathology. However, you do have some gas collections and fluid effusions which happen in these graft patients even up to 4 to 6 weeks following things. So the sensitivity of identifying graft infection is not very good. Of course, ultrasonography can guide you for FNAC. Same applies for CT and MR. Again, these gas collections around the graft up to 4 to 6 weeks, the role is not very good. Again, CT can be used for guiding FNAC. Now coming to radionuclide imaging, what is the role of radionuclide imaging in identifying graft infections? We have an array of techniques which are used to identify infection. To start with, the gallium-67 citrate, by the different methods of localization are shown, and most of these techniques are very non-specific infection. It goes to infection and inflammatory process like gallium-67, radio-labeled leukocytes, either with technetium or with indium, polyclonal immunoglobulins, monoclonal antibodies have been tried, some peptides, nanocolloids, streptavidin, biotin complexes tagged to technetium or indium have been used, and of course F18, fluorodeoxyglucose. Nowadays they have even tried some antimicrobial agents like ethambutol and fluconazole, ciprofloxacin tagged with technetium scans. All these have been tried. Since you have so many varieties, obviously not one test is very specific for infection. So indium labeled WBC scan and gallium scanning is very time consuming but is useful and has been shown to be 90% sensitive. But again, the usefulness is limited in the immediate post-op period because of active inflammatory pathology around. So this is an example of using indium labeled biotin. You can see the increased uptake all around the thigh. This was due to multiple abscesses which was confirmed on CT. And this picture shows infection in the right femoropopliteal graft. But as you can see, the images are not very, very clear, and the imaging is done over many days. So these are very non-specific kind of tests. So now coming to PET-CT. So what is PET? Positron emission tomography. Here we are using metabolic tracers, which are organic molecules which you tag them to positron emitters, and you get a functional imaging. You are studying the biochemistry of the patient, and whatever the changes happening at the cellular level is diagnosed by positron emission tomography. And when you attach it to anatomical imaging in the form of CT, the information which you get is very, very, very useful. Fluorodeoxyglucose is nothing but just plain sugar. It's an analog of sugar. It has a half-life of 110 minutes. It is a metabolic contrast agent, very safe. You have no side effects using FDG. How does this FDG get trapped? So here the glucose, it behaves exactly like glucose. It enters into the cell and gets transported into the cell and phosphorylated, but FDG does not undergo any further metabolism and gets trapped inside the cell, and that is how you are seeing it as an increased uptake. So this can happen wherever there is increased glucose metabolism, in tumors, in infection sites and ischemic myocytes. So this is the basic principle on which FDG PET is applied. This is the normal biodistribution. It goes to the brain, to the heart, and excreted through the GIT. So this is a typical picture of a PET scan. You are having a CT picture and then a gamma nuclear medicine image and the combined image which helps you in localization. So I'll just go through a couple of cases to show the importance of PET CT in infection. Here is a gentleman, 54-year-old, who received right femoropopliteal bypass graft 3 months previously. Infection was suspected as he had pain in the groin. FDG PET, that is in the center picture, shows you by the arrow a very hot spot in this region, but only the CT scan is not going to, the CT scan on the left hand side shows the graft here, and the side is normal, but once you combine, the combined image very nicely localizes the site of hotspot to the vascular graft. So he was identified as as an infectious process, and it was confirmed on surgery, and the infected prosthesis was removed. Here is another case, a 68-year-old man who received again a femoropopliteal bypass 18 months back, having symptoms of infection, signs and symptoms. You can see in the top image some increased uptake in the FDG picture, and again in the cross section it's on the medial aspect of the thigh. Then in the CT image you can see the graft here, but when you do the combined image it is not in the graft, but it is on the it is on the soft tissue. So thereby he only responded to antibiotic therapy and there was no need for removal of the graft. And another case, a 54-year-old having fever and minor defect in the right lower limb, right-sided patent femoropopliteal bypass had been performed 6 months previously. The wound was healthy. The blood cultures showed MRSA. An ultrasound examination reduced flow in the bypass graft with no exudate. And magnetic resonance showed wall thrombi and left-sided superficial femoral artery obliteration. Leukocyte count was close to the upper limit. FDG examination was performed. This is the CT picture. No specific sign of graft infection around the graft. Only a non-specific hypodense rim was seen around the graft. Here in the FDG image, you can see the complete vascular graft from its origin to the end having intense uptake around the graft. So this graft was removed and the patient did and well after removal of the graft. So there are many, these are many papers are available now where they have tried FDG PET for diagnosing infection, vascular graft infection. This is an angiology 2008 paper. 5 consecutive patients with prosthetic infection was detected, and they have shown, whichever showed intense uptake around the graft were proved to be having infection. Again, this was a most important paper which studied the graft infection, prosthetic graft infection in FDG PET. This paper showed a sensitivity of 93% and specificity of 91% and PPV of 88%, and they have shown without any doubt the reliable role of FDG PET in non-invasive imaging for vascular graft infections. So to conclude, PET-CT imaging with FDG scan effectively diagnoses graft involvement and helps us to differentiate the site of infection, whether it is in the graft or in the surrounding tissue. So this is very important. As we know, infection of a graft requires removal by surgery, whereas infection of the soft tissue in the vicinity only requires intravenous administration of antibiotics. So thank you very much for your patient hearing.